Hi everyone, thank you for joining us for our live virtual MDA Engage IBM event. My name is Nicole Petrowski and I'm the Community Education Specialist in the Community Education and Insight Department for MDA. I hope many of you were able to join us these past couple days as we've heard some fantastic presentations from Dr. Mozaffar and Dr. Alfano. The symposium has wonderful information that is devoted to the inclusion body myositis community, and I'm glad to have you all join us today. This seminar today is part of our larger MDA Engage flagship community event series, which began in 2018. It focuses on bringing the neuromuscular community together around education and social opportunities. On the slide here, you can see a list of our current Engage seminars we are hosting this year, and we are currently in the process of rescheduling our spring events, so be sure to check back to MDA Engage on mda.org for updates on the virtual and in-person events that we will be able to have this year. Like everyone else, MDA is very aware of the pandemic affecting all of us right now. Therefore, we have created a resource page dedicated to COVID-19 resources and our recommendations for the neuromuscular community. You can find that on mda.org/COVID-19, and you can get up-to-date information, participate in our MDA patient and caregiver survey, and view important recordings such as our Facebook Live events surrounding COVID-19. Just a few housekeeping items before we begin. We are recording today's event and we will be providing a copy of it on mda.org website, and it will be for on-demand viewing down the road to ensure those who weren't able to join us live today are able to access this information. Therefore, recording on your own device is unauthorized and distribution is prohibited. For those of you joining the event live, please know all phone lines have been muted. We will be having a Q&A session at the end of the presentation, so please utilize the Q&A window to type in your questions. If you hover over your screen, you will see a tray of webinar icons appear, and just click on the Q&A icon to open up that feature and type in your question. And you don't need to wait till the end of the presentation. We will be collecting them as the presentation is going, so please feel free to send those in. And before we begin, I would like to say a special thank you to our chair, Dr. Tassim Mozaffar from the University of California, Irvine, for all of his hard work in helping provide the vision, topics, and expertise for this virtual education event. It wouldn't be possible without his participation and support, so we are very grateful. I also would like to thank Elise Qualley, the Director of the Community Education and Insight Department and Chief Privacy Officer for MDA, who's assisting me with behind the scenes of the webinar today. Finally, thank you all to all of those in the IBM community who's joining us today. Our community education is so important to us, and we're happy to be able to offer such important information for you all. And as similar with the last few days, we will be taking questions after Dr. Schmidt's presentation, and we will get to as many as we can. If we do run over, please note we will be collecting those questions and we will get those responses to you. So without further ado, I would like to kick off our last day of our IBM Symposium by introducing to you our presenter today, Dr. Jens Schmidt. Dr. Schmidt is a Fellow of the American Academy for Neurology and Fellow of the European Academy for Neurology. He is a consultant and professor of neurology at the Department of Neurology in Göttingen, Germany. He is head of the Muscle Immunobiology Group and speaker of the Neuromuscular Center at the University Medical Center. Dr. Schmidt is the national spokesperson for all German centers and the European spokesperson for myositis within this network. His research interest encompasses a wide range of clinical and experimental muscle immunobiology. He has co-authored numerous high-ranking research and was trained in Wurzburg, Southampton, Guildford, and London, and he has also worked at the National Institute of Health in Bethesda, Maryland. Dr. Schmidt is a member of the most relevant national and international professional societies in the field of neuroimmunology as well as neuromuscular disorders, including IMAX. He has initiated and currently chairs the new International Myositis Society. Dr. Schmidt serves several international advisory boards and steering committees in the field of myositis and is a member of the Medical Advisory Board of the Myositis Association in the USA, as well as the Diagnostics Group Myositis in Germany. He is also co-chair of the Myositis NET, a clinical and scientific working group for myositis in Germany. He has won several national and international prizes for his research in neuroimmunology and myositis. And Dr. Mozaffar has joined us today on our last day. So Dr. Mozaffar, would you like to say a few words before Dr. Schmidt presents his slides?
Sure, thanks, Nicole, and thanks, Jens, for doing this all the way from Germany. And what you guys don't know is Dr. Jens is also on hospital service at a busy time in Germany. So he's doing this from the hospital right now. But yeah, Dr. Schmidt is one of the leaders in the field. He's really given myositis a lot of thought, especially IBM. He trained with Dr. Delakas in Bethesda. And he's going to give us some wonderful insights about swallowing issues, which is one of his favorite topics in this area. Thanks, Jens.
Dr. Schmidt, yep, go ahead and unmute and you can please share your screen.
Okay. Hello, everybody. Good day, good morning, good evening, wherever you are located. Thank you very much, Nicole, for this extremely kind and very detailed introduction. I'm really honored, and thank you very much, Tassin, for inviting me. I feel very obliged and appreciate this opportunity very much. Thank you very much also to the Muscular Dystrophy Association for hosting this webinar. I think this series is very interesting, and I was unable, unfortunately, to view the other seminars so far, but I will look at them because they're recorded for that purpose. So without further ado, the topic is swallowing issues in IBM. All of you know IBM clearly very much. Just to get started, I thought it wouldn't hurt to have a few key slides. IBM, of course, has one of the features, dysphagia, which means swallowing impairment in about 2/3 of the patients. And usually we do see an affection of the long finger flexors. The quadriceps is affected. You know that we do not have any cure for treatment available. So the disease is relentlessly progressive, and it is considered a rare disease, but still we do see quite a high number of patients recently in all areas of the world. Now, seeing that we have quite a typical presentation, just said that the long finger flexors and the quadriceps, the tibials anterior, are affected. This gives really a distinctive pattern in comparison to all other forms of myositis, and all of you are clearly aware of that this IBM looks different from other like polymyositis, dermatomyositis, and immune-mediated necrotizing myopathy. And all of you, I think, are quite aware of the facts that the pattern of weakness can be quite similar also in muscular dystrophy, which is important to bear in mind for those cases that are difficult to treat and may eventually turn out to have a hereditary condition. Now, one point that is often neglected, I would like to take the liberty to point out, although this is off the topic, if you may look at it like that, because it's not about swallowing. The case is that the pattern of weakness in IBM is very typical, but it's not exclusive. We do see an identical pattern of weakness in several forms of distal myopathies, for example, myofibrillar myopathy, and they can look really identical with a weakness of the long finger flexors. And to make it worse, the histological pattern can look even similar, and they can also have swallowing abnormalities. And now we are there, the swallowing issue. 11 years back, this is taken from a very nice publication from the Dutch group around Umesh Badreising, who's also an internationally renowned expert of IBM. They published a paper of the Videofluoroscopy in IBM. Now, first on the left, you can see a video of such a videofluoroscopy. It's a barium X-ray assessment, barium swallow, and on the right side you can see an IBM patient. So here you see this is the barium swallow, and the patient swallows again and again, and it makes you choke just by looking at it, because the patient really struggles to clear this down the throat. So the outline of the presentation is that I would like to convey a little bit of the background of what is swallowing and how does it actually work. What are the symptoms of an impaired swallowing, meaning dysphagia, and which diseases can cause dysphagia other than IBM. And I think a very important aspect is how can dysphagia be assessed? And what are the typical characteristics of dysphagia in IBM, and which other treatment modalities are available? So swallowing comes in many different flavors. Some of these cartoons are very natural, like swallowing a fish if you're a bird, swallowing a kangaroo, for example, if you're this big snake. I don't know if this really looks healthy, what this gentleman does down here, swallowing this billiard ball. Now, very important is that swallowing is an active motion. All of us, if we would be able to stand on the upside down on our head, all of us could swallow upside down easily. You don't have to train this. It works. If you like, you can try out today. Don't fall, don't hurt yourself, of course. This truly works without any problem. So it's an active motion. We do not need the gravity of the earth in order to swallow. Swallow is an extremely complex mechanism. We don't have to think about it normally if we are not affected, if we are healthy, and we do it multiple times, as I just did. The swallowing comes in various phases, and it is controlled by several regions of the brain. And this is the cortex, the medulla, so higher areas of the brain, lower areas of the brain. Several cranial nerves are involved, and over 30 muscles are needed to act in concert in order to make this possible. Now, the first phase is the oral preparation phase. And this is where the tongue sorts out where should actually the liquid or the solid food go. Then we have the oral phase where the tongue moves the food towards the end, towards the area of the pharynx, and then we get to the pharyngeal phase, and the last phase is when the food actually enters the esophagus and can travel towards the gastric area. This is a picture more for medical professionals, just to give you an overview of all these anatomical landmarks and muscles, which are noted here. I don't want to pronounce any of these difficult Latin words. This is just to provide an image of some of these 30 landmarks and muscles, which are needed for this one swallowing time of about 1.5 seconds given here, just as an image. Now, which other diseases other than IBM can cause swallowing? It's a really common symptom. We see it in stroke, we see it in Parkinson's disease, in ALS, in myasthenia. So these were all neuromuscular disorders, in tumor disorders, but also in mechanical strictures or dilations. In IBM, we already said that dysphagia is common and it clearly leads to a reduced quality of life. There is a risk of aspiration and malnutrition. Swallowing impairment can cause death by pneumonia or directly by the aspiration, and this is clearly significantly increased in IBM. On the contrary, although this is so severe and so important, dysphagia is often overlooked by patients and caregivers, particularly in the early phases of swallowing symptoms. And the reason is that patients often do not report about swallowing abnormalities, even when they're specifically asked. And the reason for that is that there is for this reduced perception that the impairment may occur slowly, progressive, and typically these swallowing difficulties are not perceived as related to the disease itself, but to general aging. So towards diagnostics, I would like to mention 5 different items. The first, some direct questions that you may tell your physician that he or she should ask in order to make sure if there is swallowing abnormality present or not. Then there are several detailed questionnaires which I find extremely helpful in order to pinpoint if or if not swallowing abnormalities are present, and particularly to have a follow-up possibility for the next visit or even at home in order to make sure, does it become worse or is it stable? Then there is technical methods, the flexible endoscopic esophagoscopy, FOIS, the videofluoroscopy, which we've already seen in the beginning, X-ray assessment of the barium swallow, and then as a research-based technique, real-time MRI of swallowing. So I would like to take you through these 5 different methods. So at first, the direct questions regarding swallowing performance. This is a collection of questions. Some of them may work for you, some of them may not. There may be other questions that may work better for you. Do you experience difficulty chewing solid or liquid food? Are there any food residues in your mouth after swallowing? Do you have to swallow multiple times or in small portions? Do you choke or cough during eating? Do you have to clear your throat after swallowing? Does food get stuck in your throat? Does eating take longer than normal or previously? And did you change your eating habits? For example, avoid certain food that you would like to eat? The detailed questionnaires, this is more complex. Still, I think it's important. It's the swallowing quality of life, 13 questions scored from 1 through 5. The Sydney swallowing questionnaire, 17 questions on a visual analog scale. Then the more simple functional oral intake scale. And then again, a complex scale, MD Anderson Dysphagia Inventory, with 19 questions scored 1 through 5. I would like to show, just to give an overview of what each questionnaire is about. So the swallowing quality of life questionnaire covers many more areas than the actual swallowing itself. So I think this is a very unique scale, and it reflects more the problems of swallowing problems later on. So I think in an essence, like for example, as a treatment following scale, I find it less easy, less straightforward, but this others may have different opinions. So it covers the food selection, the burden of the swallowing, and then of course some actual symptoms like choking, or if the saliva can't be swallowed, then if eating habits have changed, and then actually if there's a fear associated with eating. The Sydney Swallowing Questionnaire is clearly my favorite. It is also long, it covers several questions, but I think they're all very pointed, very straightforward, and really down to the actual meaning of swallowing. All of them are visual analog scales, so you as a patient can just tick mark if there is no difficulty or if you are unable to swallow. For example, the first question, how much difficulty do you have swallowing at present? Then the thin liquids problems, thick liquids problems, the soft foods. It continues with hard foods, dry foods, the saliva, and difficulties in initiating the actual swallowing process. It continues with if you have the feeling of the food getting stuck in the throat, if you have to cough or choke when you swallow solid foods, or if you cough or choke when you swallow liquids. Then how long you actually need for an average meal. Here you can just tick one. Then the next one is if you need to swallow more than once, and if you cough or spit during a meal. If there is the severity of the swallowing today, and if there is an interference with the enjoyment of quality of life. So there is one question also associated with the quality of life. So I think this really covers many important aspects of swallowing. The functional oral intake scale is very simple. It's just 7 levels. The first 3 levels are for those that really need a gastric feeding tube. 1 would be the weakest level with no oral intake, then tube dependent with minimal inconsistent oral intake, then with some consistent oral intake. Then from 4, it'll be a total oral intake with a single consistency for the 4, multiple consistencies as a 5, then no special preparation, but avoid specific foods is a 6, and then without any restrictions is level 7. That means completely normal swallowing. The last one is the scale that I have the least experience with. I find it a little bit difficult because it covers several different areas and is less detailed. It's like a mixture of the swallowing quality of life scale and the Sydney Swallowing Questionnaire, but both of them are not followed through completely. But there are more questions, for example, if it impairs the day-to-day activities and eating habits, and then if you're embarrassed to eat, and if you have weight loss, for example, or if the self-esteem is impaired. The first technical measurement is the flexible endoscopic evaluation of swallowing, the FOIS. This may look difficult, and it may make you vomit if you just look at it. If it's done right, it can be a very smooth, straightforward, easy procedure that is usually a bedside test. It can be done in every outpatient setting. It's a quick test, and you can stop it at any point. The tube is inserted into the nose, and the tube contains a camera at the end and a light bulb. And you can then, as a physician or caregiver, you can look from the top in to the throat, and you can actually watch the subject or the patient while he or she swallows, and we will see images of this. The next one is the videofluoroscopy of the barium swallow, assessed then by X-ray. And this is how one of the movies that we did at our center. It's similar to what we saw initially. This is an IBM patient with a major swallowing problem. The research technique is the real-time MRI. This is only available in some centers that have a research interest. So the goal was of this research study, if the real-time MRI was useful to detect swallowing abnormalities in IBM patients, to see if MRI was safe in a lying position, and if the tissue assessment would add relevant information compared to the videofluoroscopy. The technical examinations included the real-time MRI, the videofluoroscopy, and the FOIS. And we had the swallowing quality of life scale, the Sydney swallowing questionnaire, the functional oral intake scale, and then the typical IBM functional rating scale. I'm sure that most of you are already familiar with that. It's a scale that covers many typical functions of hands and legs, and are often impaired by patients with a typical cause of IBM. There was the clinical examination with the MRC sum score. This means that a physician studied the muscle function of both arms and legs and noted the muscle research council scale from 0 to 5 and then made the sum score. We included 20 patients on a non-selected basis. The mean age was 73. There was large portion of the patients with an impaired mobility. Many patients received some treatment. Not all of them were from our center, so some of them received immunosuppressants, which today we usually would avoid in IBM. Almost all of them received some form of physiotherapy or speech therapy, and a large portion of 80% actually had symptoms of dysphagia. So the methods, we already said, videofluoroscopy and the FOIS. And this is how a FOIS looks like in an IBM patient from this study without any problem. So here you can see the throat, there is no problem. The patients are given 1 teaspoonful of green liquid. And here you can already see that this is before the patient swallows this time, that there had been 1 swallow before this movie, and the patient had difficulties in swallowing this. Now there is the teaspoonful given and the patient swallows and again, and you can see that this green stuff covers all areas around the whole throat and the patient cannot get rid of it, and now the camera gets blurry because this green stuff covers all area. The same patients now by videofluoroscopy, so an IBM patient without any dysphagia. This is straightforward. The contrast agent goes all the way through. And on the right-hand side, a patient with severe dysphagia. We've already seen this 2 times. And we can see that there is the contrast agent sitting at the in the pharynx, just above the upper esophagus sphincter. This is supposed to open, but for some reason we do not understand fully, it doesn't open, and that's why there is an insufficient passage of this barium. Now, the research tool was a standard MRI scanner. So actually this could be done in many centers in the world, but the actual sequence is something that is not covered by the standard scanner. So this is beyond the standard approach. So the scanner is standard. but the way the scanner works, like the software and the sequence, the flow of the assessment, this is something that is unique, and you need to know how to control the scanner in order to obtain those images. So this is the lead author of the project, my colleague, Dr. Per-Ole Carstens, and he's standing next to the scanner, and he holds a big syringe, which is connected through a very, very tiny little drip into the mouth of the patient. And this syringe contains pineapple juice, just a small bit, 5 milliliters. And why pineapple juice? Because it contains natural manganese, and this can be seen as a contrast agent in MRI. So on the left side, we see this pineapple juice piling up, and now the patient is asked to swallow, and we can see the nose, we can see the tongue, we can see the spine, and we can see the glottis, and we have seen that the patient had no problems in swallowing. And on the right side, you can see the end of this little hose, and here you can see the pineapple juice coming up. The patient swallows, and we can see exactly the same what we saw before, that the pineapple juice sits there, sits there, sits there. The patient swallows multiple times. Now, in addition to all what we saw before, we can see the whole image, we can see where it is, we can see the spine, we can see all the soft tissue, so we get a much better impression of the anatomical landmarks of what function and what doesn't function. So we looked at the MRC, and of course we saw that many patients had weakness, others were not as weak. The IBM FOIS was quite scattered. Some patients impaired, some patients did fairly well. The swallowing scales, Swallow and SSQ, again showed that some patients were almost completely normal and had no symptoms, and some patients were severely affected. The FOIS was much more clumped together because it's just a 7-level scale, as you saw earlier. And now the actual technical results, the MRI showed just as much as the videofluoroscopy and the FOIS, all the swallowing impairments. So the MRI actually did what we were hoping it would do, and we could clearly see that there was a significant correlation of the findings that we saw by MRI as well as with the videofluoroscopy or with the FOIS. And here you can see the blue line, the correlation is significant for the FOIS, and the red line, the correlation is significant between MRI and videofluoroscopy. All of the three measures, as we would expect, correlated significantly with the swallowing scales. Here, the correlation with the swallow, they were all highly significant, and we found an equal result for the Sydney swallowing questionnaire. I won't show it. Now, what we can do with the MRI, which is more difficult with the other techniques, because with the MRI we can really pinpoint milliseconds almost, is that we can easily measure the actual timing of the swallowing and the different phases of the swallowing, the oral part of the swallowing, the pharyngeal part of the swallowing, and the esophageal part of the swallowing. And we compared the values of our 20 patients with IBM with previously published values from a control cohort, and we saw clearly highly significant prolonged oral time, a very highly significant and clearly very, very long passages, sometimes for individual patients, multiple times higher compared to the control group in the pharyngeal time, and also the esophageal time was prolonged. It was it was less diverse. So the biggest problem was in the pharyngeal part. And the reason why there was the problem in the pharynx is that we saw a cricopharyngeal bar. This means that the upper esophagus sphincter, the gatekeeper of the swallowing mechanism, seemed to remain closed. And this cricopharyngeal bar, the dimension in centimeters correlated highly significantly with the time that the food needed in order to pass down the pharynx. This means the bigger the pharyngeal bar, the more swallowing problems occur. And this is something which has just this year been confirmed by a Japanese group. They couldn't use the real-time MRI. They used the Videofluoroscopy, which works just as well, but we don't see the soft tissue, and we cannot perform this milliseconds timing, but still they saw the identical bar as seen here, and they could find that if this bar was present in this table, CBP+, that more than half of the patients had a sign of aspiration in the Videofluoroscopy, and this was no patient at all in those patients that did not have this bar. And they then calculated the risk factors for aspiration pneumonia and found that this cricopharyngeal bar was clearly a risk factor, which was significant in this cohort of patients that they looked at. And they then looked over several years and followed these patients and could show that out of 13 patients which showed this bar at over 6 years, except 2, all of them experienced an aspiration pneumonia, which is clearly important and clearly shows that this is a major problem in IBM when you have this cricopharyngeal bar, compared to those patients, the blue line, which did not have this. They hardly experienced an aspiration pneumonia. So the conclusions of the study were that the symptoms are present in the majority of the patients. The real-time MRI was safe and feasible. There was a significant correlation between the techniques, but the advantage of the MRI was that we could see the soft tissue and that we did not need the X-ray exposure. The real-time MRI is believed to be suitable for longitudinal studies in IBM, and it can be applicable to other disorders with swallowing abnormalities. So lastly, I would like to talk about the treatment of dysphagia in IBM. This is an important but difficult topic. So the goal should be to avoid weight loss and to avoid cachexia. The patients should receive some form of speech-language treatment regularly. You should modify your eating habits if you're affected by dysphagia. For example, eat more often in smaller portions, eat slowly, carefully, drink water as you eat, and avoid bigger chunks with a possible risk of aspiration, and use a high caloric diet. A feeding tube should be considered when when the normal eating becomes insufficient for calorie uptake, and it should be used to reduce the risk of aspiration, which has the potential of causing a pneumonia or even death. There are experimental forms of treatment for dysphagia in IBM. One is the balloon dilation. This has been published as case series several times. Personally, and this is with all our experience from the center, from our ENT colleagues, experts, we would not use, and we haven't used, and we would rather discourage from using this technique, although others may have positive experience. The reason for saying that is when we really look into the pharynx, we do not see a permanent stricture. So we don't see some tissue which should really be dilated. So we would rather worry if we would actually pose some additional damage which would actually cause trouble later on. One clearly effective method is the myotomy. It's a surgical procedure. It is irreversible. It means that the cricopharyngeal muscle, this gatekeeper for swallowing, is cut. And this is probably the most effective treatment, but since it is irreversible, the side effects, if they occur, for example, some regurgitation, that they may not, or for example, heartburn, that these symptoms may not go away. One treatment that we use at our center very much is the local injection of botulinum toxin. This needs to be inserted inside the pharynx, and I will show a picture here. So this is taken from a recent publication, not from us, from another group, where you can see a picture as the doctor inserts a needle into the esophagus and applies the botulinum toxin inside the cricopharyngeal muscle. There are more publications, like in 2016, and overall over 20 patients so far have been reported in the literature from different countries, different physicians, different groups. These are all retrospective studies, and the effect has been more or less positive, not 100%, but many good experience. And importantly, there have been so far no major complications in these studies. So this is how we saw one patient with botulinum toxin before on the left-hand side and after the treatment. So these movies have been started at the same time, and you can see that there is swallowing going on the left, and on the right, the passage has already been cleared. So in summary, swallowing is a common and severe symptom in IBM. It should be specifically asked for. Standardized questionnaires should be used. The real-time MRI is able to demonstrate the underlying functional impairment, and injections of botulinum toxin may serve as an experimental treatment option for severe dysphagia. One last item is the pharmacological treatment. To say it up front, this is extremely controversial, and there is no international consensus of the use of immunoglobulin G in IBM. There is no licensing whatsoever. This is completely off-label, but all in all, there are over 100 patients that have been published in the international literature, plus in addition many other patients who have received immunoglobulin intravenously or subcutaneously, and there have been shown in these different case series, clinical trials, or case reports some temporary positive effects of immunoglobulin on dysphagia. So this could potentially, on an individual basis, be something that could be considered. So I would like to acknowledge all my co-workers from our center, from the ENT department, from the Department of Neurology, from our Max Planck Institute for NMR research, and from our Department of Radiology. This is our University Medical Center. And I thank all of you for attention. Thank you.
Thank you, Dr. Schmidt, for that informative presentation. That was a lot of information. I do want to take this time now to open up to any questions our audience may have. We will conclude this presentation about a minute before 1, so I will get to as many questions as we can. Just to note too that the MDA resource staff are available Monday through Friday from 9 to 5 and are typically able to answer any questions that you may have within 1 to 2 days. So please take note of that phone number and email. So let me look at our questions. All right. Is there any research on CAR T therapy for IBM?
Sorry, CAR T therapy?
CAR-T.
What I see that. Could you please tell me what this stands for? Because I haven't heard about it.
Jens, if I may.
Please.
So CAR T therapy are chimeric therapies. So they create chimeric T cells from the patient's own blood, and they're directed against a particular antigen. So for instance, it's tried in cancer. There is a trial going on right now for myasthenia gravis where they are creating these chimeric towards the acetylcholine receptor carrying T cells. There have been discussions about creating similar CAR T cells for IBM, but right now nobody has these cells because it's difficult to really target a antigen because there is no defined antigen in IBM. So that's been one of the challenges in trying to understand how you create a CAR T cell.
Thank you, Tassin. So I'm learning something.
Okay. This person's asking, I was diagnosed with IBM about 12 years ago. I have experienced aspiration, but I have an inordinate amount of phlegm causing me to cough a lot. Is this normal for IBM?
Sorry, I was trying to look at it at the same time. Can you say it again, Nicole, please?
I was diagnosed with IBM about 12 years ago.
Okay.
I have experienced aspiration, but I have an inordinate amount of phlegm causing me to cough a lot. Is this normal for IBM?
An enormous amount of phlegm?
Yes.
Sorry, can you explain, please?
Phlegm, it would be getting stuck in your throat after you eat.
Okay. Okay. Well, this is probably exactly what happens in IBM, that the food that you can chew, that it can pass through the mouth and that it then gets stuck inside the pharynx. That this is exactly what happens in IBM.
Okay. This person's asking, I've had IBM symptoms for 20 years, officially diagnosed 15 years ago. I have no swallowing issues yet. What is the likelihood I will have swallowing issues in the future?
We can't tell. So it is, there is a broad spectrum. Some patients have it initially as a sole symptom for several years, as the initial presenting symptom. And some patients never get dysphagia or relevant dysphagia. This is at the moment, as far as I know, unpredictable.
Okay. This person's asking, I have had 4 VF swallow studies since April of 2014, and the results have been mixed. They are not consistent in that there is not a downward progression in my swallowing abilities. Do you have any suggestions about how to address this issue? I am on a vent with a trach, and I find I swallow better now than before with the trach.
This is interesting, and I think it would be good to also follow up the swallowing scales in order to see if this maybe is a problem of the videofluoroscopy, or if really the symptoms or which part of the symptoms have improved. If the muscles change, the affection of the muscle can change over time, And as we, for example, see some patients in response to treatment sometimes really improve significantly regarding the swallowing function.
Okay, thank you. I have IBM diagnosed 6 years ago. I had a myotomy 5 years ago and was successful and helped my swallowing. However, it seems like swallowing is becoming more difficult again. Is this normal? Can I have another procedure in the future?
This is interesting. Unfortunately, I cannot explain from my own personal experience because we do not follow these patients, because this procedure, I don't know of any German patient on the top of my head, and we have a large cohort, probably the largest cohort in Germany. This is something people from the UK, US, Netherlands would need to answer. Yes, I've seen such reports. That there is a reoccurrence of swallowing problem. To our current understanding, this shouldn't happen. I cannot tell why, because we, and I think we should study what's going on in terms of videofluoroscopy and MRI studies in order to understand which part of the swallowing is affected now that the bad guy should be switched off. So I can't give a good answer to that.
Okay. Are there any exercises to strengthen throat muscles?
To strengthen
throat muscles.
This has been studied. And I think it hasn't come out yet. I think the group around Mary Needham in Australia has just studied a unique exercise program, but this study, as far as I heard, the results were negative. So in terms of really providing a significant effective approach for IBM swallowing.
Okay. Are the vocal cords part of the swallowing process? If so, can singing or certain vocalizations help in slowing down the weakening process?
Not that I would know of. No, the vocal cords are not part of the swallowing progress. They are covered during the part of the swallowing.
Can vocal cords become paralyzed with Botox injections?
No, not if it's done correctly, because the injections are done below the actual vocal cord area, and they are done not into the larynx. They are done on a level further below. If it's done properly, the injection should go into a different place.
Okay. Would an injection of, and it's that really long word, but I think it's Botox, help slow or eliminate excess saliva?
Into the injection into the upper esophagus sphincter would, if the swallowing is improved, then the clearance of the saliva is improved, but the production of the saliva remains the same. So in order to reduce the production of the saliva, other parts of the body, for example, the parotid gland, would need to be injected, or other mechanisms or pharmacological treatment need to be tried.
One person is asking, what should we do if we are alone and start choking?
This is the problem.
Okay.
So if you're worried about this to happen, and if you had like events like a near choking event, it would be good to have like a button that you can press for help, to call 911, or to call someone in the household, or like an automatic phone going on, because this is an emergency.
Okay. I am on a feeding tube with a J tube as I aspirate easily. I have had several bouts of pneumonia and have been intubated several times. I have excessive amounts of phlegm. Currently, I am managing well, working with Mayo Clinic. However, I cannot go there now. My main complaint at this time is my voice is very, very weak. Do you have any suggestions?
This is a very complex situation, which is really difficult to discuss with this information. I can see that this is really complex. I don't know how it happens. If the whole oral intake is only through the gastric feeding tube, I don't know if this person also eats in addition to that. So I think we would need more information in order to provide a good answer to that.
Okay, I'm just checking our time. We have a couple more minutes. One question that we have is, I have been diagnosed with IBM. I have had symptoms in the arms, hands, calves, and quads. I also have severe atrophy in my left shoulder and chest muscles. This seems to be consistent with distal myopathy according to the first part of your presentation. Is there a difference? And if so, does that mean it can be treated?
Yes, there is a difference in terms of inheritance, because the myofibrillar dystrophies, they are inherited diseases, whereas we would assume that inclusion body myositis is not a monogenetic mediated disease. So it would be good to know. On the other hand, it means that if we would know that this is a genetic cause, we would stop immunosuppression, stop immunomodulatory treatment. However, so far there is no gene treatment available for these diseases, although several gene treatment approaches are underway. So it would be good to know in order for maybe the future genetic efforts in clinical trials, for example.
Okay.
So if someone thinks that he or she has a hereditary condition being misdiagnosed with IBM, it might be an idea to do genetic testing.
Okay, that's very good to know. Where does the mucus that comes up in my throat during the night come from? And is there any way you can limit that?
Probably this is due to insufficient swallowing of the saliva during the nighttime. So this, in a situation like that, there should be a proper workup with the diagnostic approaches that we discussed with the FOIS and maybe the Videofluoroscopy, etc., and to look at the appropriate scales. Is there a problem even maybe during the day that you may not be actually aware of, and then potentially provide a treatment.
Okay. Would swallowing tests be part of a natural history to help find appropriate trials?
Yes, so we are we have, for example, a national registry where we include also the swallowing questionnaires in order to provide a better natural history of the history of the severity of swallowing issues in a large cohort of patients. We're currently collecting this information.
Okay. All right, and we can do, let me take one more. This person is simply asking, what does Botox do?
The Botox is like it's a poison which blocks the neuromuscular transmission. It's like pulling the plug out of the transmission of the signal going to the muscle in order to contract. If so the muscle cannot be controlled at all, and the muscle will become lame. So this is why it's used, for example, as a wrinkle treatment or whatever. So the muscles will not work.
Okay.
for some time, and then it will vanish. So in IBM, the effect lasts from 2 months up to 6-8 months sometimes, so much longer than in other diseases. So for example, in dystonias, when we inject botulinum toxin, we usually have to give it every 2, 3, 4 months.
Okay. And the last question, we've had a couple people actually type in, are tonsils involved in any way?
Not that I would know of in IBM.
Okay, okay. Well, I want to be conscious of our time that we have. I know you are on call at the hospital, and so I definitely appreciate your time. I do know that we do have other questions that we haven't been able to get to, and we will, like I said, consolidate those and get you some answers as soon as we can. Also, in the future, if you do have questions, please feel free to email them to the email that you see on the screen, mdaengage@mdausa.org. And remember, we will be emailing you a survey to hear about your experience with our IBM Symposium. So thank you in advance for taking a few minutes to respond to that. Dr. Mozaffar, would you like to say anything in closing?
No, I think this was a very helpful and very informative lecture. And I think it really highlights the need to further define proper diagnosis of swallowing dysfunction as well as newer treatment modalities for it. So I think this was incredibly helpful.
Okay. Well, thank you again, Dr. Schmidt. Thank you, Dr. Mozaffar. And thank you, everyone, for participating. It's been a pleasure spending part of the week with you, and we hope that you did learn a lot. So thank you very much for attending, and have a great rest of your day. Bye.
Thank you. Bye-bye, everybody.
Mm-hmm.